Today's quiz is on non-steroidal anti-inflammatory drugs, commonly known as NSAIDs, which play a major role in pain, fever, and inflammation management. This quiz features 10 multiple-choice, scenario-based questions designed to test and strengthen your pharmacology knowledge. Each question includes 5 options, followed by the correct answer and a clear explanation. For a deeper dive into the key concepts of NSAIDs, check out the companion review video linked in the description. So, let's begin. Question 1. Mr. Anderson, a 56-year-old man with osteoarthritis, presents with worsening knee pain unresponsive to acetaminophen. He is prescribed naproxen 500 mg twice daily. His past history includes hypertension and controlled gastroesophageal reflux disease. On review, he asks about the pharmacological action of NSAIDs. Which of the following best describes the mechanism of action of NSAIDs in reducing pain and inflammation? Option A, inhibition of phospholipase A2 enzyme, preventing arachidonic acid release. Option B, direct antagonism of prostaglandin receptors in synovial tissue. Option C, inhibition of cyclooxygenase enzymes, reducing prostaglandin synthesis. Option D, activation of lipoxygenase pathway to decrease leukotriene formation. Option E, blockade of TNF-alpha receptors in synovial fluid. The correct answer is option C, inhibition of cyclooxygenase enzymes, reducing prostaglandin synthesis. The explanation is that NSAIDs act by inhibiting the cyclooxygenase enzymes, also known as COX-1 and COX-2. This reduces the synthesis of prostaglandins, which are key mediators of pain, inflammation, and fever. By lowering prostaglandin levels, NSAIDs provide both analgesic and anti-inflammatory effects. The other options describe actions of different drug classes, not NSAIDs. Question 2. Mrs. Thompson, a 44-year-old woman, is started on diclofenac for chronic lower back pain. She has a history of peptic ulcer disease and controlled hypertension. She is concerned about adverse effects and wants to know what to expect. All the following are possible adverse effects of NSAIDs except: Option A, gastrointestinal bleeding and ulceration. Option B, increased risk of myocardial infarction. Option C, acute kidney injury due to reduced renal perfusion. Option D, bronchospasm and aspirin-sensitive asthma. Option E, hypoglycemia in diabetic patients on insulin. The correct answer is option E, hypoglycemia in diabetic patients on insulin. The explanation is that NSAIDs do not directly cause hypoglycemia in patients on insulin. Their adverse effects are mostly linked to prostaglandin inhibition, which affects the gastrointestinal, renal, and cardiovascular systems. They also may trigger bronchospasm in patients with aspirin-sensitive asthma. Therefore, all other listed effects are recognized risks of NSAID therapy, except hypoglycemia. Question 3. Mr. Carter, a 63-year-old man with coronary artery disease, is prescribed low-dose aspirin after angioplasty. He also takes warfarin for atrial fibrillation. During a review, his INR is noted to be above therapeutic range. Which of the following statements regarding the drug interaction between aspirin and warfarin is most accurate? Option A, aspirin reduces warfarin absorption from the gastrointestinal tract. Option B, aspirin displaces warfarin from plasma proteins, increasing bleeding risk. Option C, warfarin accelerates aspirin metabolism via CYP450 induction. Option D, aspirin enhances warfarin renal clearance, lowering INR. Option E, warfarin prevents aspirin acetylation of COX-1, reducing efficacy. The correct answer is option B, aspirin displaces warfarin from plasma proteins, increasing bleeding risk. The explanation is that both aspirin and warfarin are highly protein-bound drugs. Aspirin can displace warfarin from binding sites, raising the free plasma concentration of warfarin. This increases the anticoagulant effect and bleeding risk, as reflected in a high INR. The other options are incorrect mechanisms and do not explain the interaction between these two drugs. Question 4. Miss Davis, a 22-year-old woman, presents with painful dysmenorrhea and is prescribed ibuprofen 400 mg 3 times daily. She asks how the drug helps in her condition. Which of the following best explains the indication and clinical use of ibuprofen in primary dysmenorrhea? Option A. Reduces leukotriene-mediated uterine vasoconstriction. Option B. Suppresses serotonin-mediated pain signals in uterine tissue. Option C. Inhibits prostaglandin synthesis, reducing uterine contractions. Option D. Enhances uterine blood flow via nitric oxide release. Option E. Directly antagonizes oxytocin receptors in the myometrium. The correct answer is option C. Inhibits prostaglandin synthesis, reducing uterine contractions. The explanation is that dysmenorrhea is largely driven by excess prostaglandin production in the endometrium. Prostaglandin stimulates strong uterine contractions, leading to pain and cramping. By inhibiting prostaglandin synthesis, ibuprofen reduces the frequency and intensity of these contractions. This makes NSAIDs the first-line treatment for primary dysmenorrhea. Question 5. Mr. Robinson, a 71-year-old man with chronic renal insufficiency and hypertension, was recently prescribed indomethacin for a gout flare. 2 weeks later, he presents with worsening creatinine and reduced urine output. Which of the following best explains why NSAIDs are contraindicated in such patients? Option A. NSAIDs increase glomerular filtration by dilating afferent arterioles. Option B. NSAIDs decrease prostaglandin-mediated afferent arteriolar vasodilation. Option C. NSAIDs enhance angiotensin II-mediated efferent arteriolar dilation. Option D. NSAIDs inhibit tubular secretion of creatinine, falsely elevating values. Option E. NSAIDs reduce aldosterone secretion, leading to hyperkalemia. The correct answer is option B. NSAIDs decrease prostaglandin-mediated afferent arteriolar vasodilation. The explanation is that prostaglandins normally dilate the afferent arteriole, helping maintain renal blood flow, especially in compromised kidneys. NSAIDs block prostaglandin synthesis, causing constriction of the afferent arteriole. This reduces glomerular filtration and can precipitate acute kidney injury. Patients with pre-existing renal insufficiency are therefore at higher risk of nephrotoxicity from NSAID use. Question 6. Baby Evans, a 9-month-old infant weighing 8 kilograms, is brought to the pediatric clinic with high fever and irritability. The physician prescribes ibuprofen. Which of the following dosing regimens is most appropriate for pediatric administration of ibuprofen in this infant? Option A. 100 mg per kilogram every 6 hours orally. Option B. 10 mg per kilogram every 6 to 8 hours orally. Option C. 50 mg per kilogram every 12 hours intravenously. Option D. 25 mg per kilogram every 4 hours orally. Option E. 1 mg per kilogram once daily orally. The correct answer is option B, 10 mg per kilogram every 6 to 8 hours orally. The explanation is that ibuprofen in children is dosed at 5 to 10 mg per kilogram every 6 to 8 hours by mouth. This regimen safely provides effective antipyretic and analgesic effects while minimizing toxicity. Higher doses such as 25 or 100 mg per kilogram are unsafe and may cause severe adverse effects. Very low doses, like 1 mg per kilogram daily, are ineffective. Question 7. Mrs. Walker, a 34-year-old pregnant woman at 32 weeks gestation, is taking naproxen for chronic rheumatoid arthritis pain. She asks about the safety of NSAIDs in pregnancy. All of the following are correct about NSAID use in late pregnancy except Option A, may cause premature closure of ductus arteriosus. Option B, may impair fetal renal function leading to oligohydramnios. Option C, may prolong labor and delay parturition. Option D, may increase maternal risk of postpartum hemorrhage. Option E, may reduce risk of neural tube defects when taken in third trimester. The correct answer is option E, may reduce risk of neural tube defects when taken in third trimester. The explanation is that NSAIDs do not reduce neural tube defect risk and are not protective in pregnancy. Instead, they are linked with serious late pregnancy complications, including premature ductus arteriosus closure and impaired fetal kidneys. They can also prolong labor and increase maternal bleeding risk after delivery. Neural tube defect prevention is associated with folic acid, not NSAIDs. Question 8. Mitchell, a 50-year-old man with alcoholic liver disease, presents with severe epigastric pain. He has been self-medicating with over-the-counter ketoprofen for joint pain. Labs reveal ALT 190 units per liter and prolonged prothrombin time. Which of the following best explains how NSAIDs are metabolized and why liver disease may worsen their toxicity? Option A. NSAIDs are primarily excreted unchanged in urine, unaffected by hepatic impairment. Option B. NSAIDs undergo extensive hepatic metabolism via CYP enzymes, leading to accumulation in liver disease. Option C. NSAIDs are converted to inactive metabolites in the kidney, increasing risk in renal impairment only. Option D. NSAIDs bypass hepatic metabolism and are detoxified via pulmonary excretion. Option E. NSAIDs are directly conjugated to bile salts, reducing toxicity in cholestatic disease. The correct answer is option B. NSAIDs undergo extensive hepatic metabolism via CYP enzymes, leading to accumulation in liver disease. The explanation is that most NSAIDs are metabolized in the liver through cytochrome P450 enzymes. In patients with liver disease, this metabolism is impaired, resulting in higher drug levels and increased toxicity. Hepatic dysfunction also enhances the risk of gastrointestinal bleeding and clotting abnormalities. Therefore, liver disease amplifies the risks of NSAID therapy. Question 9. Mr. Harris, a 47-year-old patient with rheumatoid arthritis, has been prescribed long-term celecoxib. He asks how COX-2 inhibitors differ from traditional NSAIDs. All of the following statements about COX-2 inhibitors are correct except Option A. They selectively inhibit inducible COX-2, sparing COX-1 at therapeutic doses. Option B. They reduce the incidence of gastrointestinal ulceration compared to non-selective NSAIDs. Option C. They are associated with increased cardiovascular risk due to imbalance in prostacyclin and thromboxane. Option D. They have no effect on renal prostaglandin synthesis and therefore are always safe in kidney disease. Option E. They are useful in patients with history of gastric bleeding requiring NSAID therapy. The correct answer is option D. They have no effect on renal prostaglandin synthesis and therefore are always safe in kidney disease. The explanation is that COX-2 inhibitors still affect renal prostaglandins and can impair kidney function. Their advantage lies mainly in reduced gastrointestinal toxicity compared to non-selective NSAIDs. However, they increase cardiovascular risk due to reduced prostacyclin without reducing thromboxane. Thus, their renal safety is not absolute, and option D is incorrect. Question 10. Mrs. Miller, a 62-year-old woman with rheumatoid arthritis, has been on high-dose indomethacin for several weeks. She presents with confusion, dizziness, and tinnitus. The physician suspects salicylate toxicity like adverse effect due to NSAID overdose. Which of the following is the most appropriate antidote or management strategy for severe NSAID toxicity? Option A. Administration of intravenous acetylcysteine. Option B. Alkalinization of urine with intravenous sodium bicarbonate. Option C. Administration of flumazenol. Option D. Immediate use of naloxone infusion. Option E. Intravenous vitamin K. The correct answer is option B. Alkalinization of urine with intravenous sodium bicarbonate. The explanation is that severe NSAID toxicity can be managed by enhancing drug elimination through urinary alkalinization. Sodium bicarbonate increases renal clearance of acidic NSAIDs and salicylates. Supportive care is also essential, including hydration and monitoring electrolytes. Other antidotes such as acetylcysteine, naloxone, or vitamin K are not appropriate for NSAID overdose.
Conclusion. That wraps up our revision on non-steroidal anti-inflammatory drugs, NSAIDs. I hope you found this quiz session engaging and informative. To deepen your knowledge further, consider reading resources like Katzung and Trevor's Clinical Pharmacology, Rang and Dale's Pharmacology, and the British National Formulary, BNF. These references will solidify your understanding and enhance your preparation.